Good day, good day. Thank you for coming today, faculty and every level of educatee. When I chose this, there's a reason I chose to speak on this, obviously. It's because it's one of my passions. Are my eyes going, or was this automatic adjustment? Anyway, it's certainly one of my passions, and I'm hoping to help you see that it actually should be one of your passions, no matter where you are and what level of practice you have at the present time. Instead of going into the meat and the fat and the gristle and everything of stewardship, this first time I thought I might call these Phase 1 or Phase 2 lectures. And hopefully as we evolve a bit, I will be able to speak to surgical stewardship, pharmacological stewardship. I mean, we're going to have our pharmacists well involved here. Everybody in here involved. Quality. Let's see, our director of quality is not. Is not here. But anyway. Oops, we're not moving forward anyway. Oh, here we go. Okay. Actually, this had Ray on it, which is my name, Raymond, right? So we go here, and this is probably maybe a function of age too, because here's my PowerPoint. And as somebody said, well, he was quite nervous when he presented it, but actually it was quite electrifying. So these are the challenges. And these are I guess, just overall statements too. From cradle to grave, we know antimicrobials have become critical in safeguarding the overall health of human society, of our human race at the present time. I know, a broad statement, but true. And resistance, which is evolving, is not just an infectious disease issue. It's a surgical issue, a cancer issue. It's an entire health system issue. Resistance of antimicrobials. So here's a broad definition of antimicrobial stewardship. So it's a practice for all of us that ensures the optimal selection, the optimal dose, the optimal route of administration, and the duration. And one of the hardest things to do up front is, first of all, decide to give an antimicrobial agent or not. It's so easy to give an antimicrobial agent. What the heck's going to happen? Patient may get a rash. They actually could get better, right? But what we want to do is identify if we have something we're going to treat, then how long are we going to treat it? And I'll point out how some of those things have changed over the last few years. Okay, and so it leads to the best clinical outcome, which we'll address in a while as well, for the treatment or prevention of infection. One of the largest users of antimicrobial agents are surgeons, right? Because surgeons use them for prophylaxis more than any of us do. And then produce the fewest possible side effects and the lowest risk for the emergence of resistance. So the treasure we call antimicrobials. So in 1928, Sir Alexander Fleming said, hey, that mold is not just your average mold. In 1942, a purified derivative, this wasn't Fleming, and in 1945, after it was used in the military, was widely available. Then we had the golden era of antimicrobial agents. Hand over fist, we were developing novel antimicrobials from the 50s and 70s. Then, so we're almost 50 years later, and we still don't have a novel, and we can argue this point, sorry. I think that's me. Anyway, antimicrobial agent. Since they're either Me Too's or they are modifications on a already existing molecule. So the life expectancy rose from 47 to 79 years, and actually from 65 up, improved from 4% to 13% of lifespan. So today, in this developed world, we have an infectious disease problem became the problem of the elderly, the cancer patient, the transplant patient, the surgical patients, and patients now on a variety of immune suppressive drugs, and again, in developed countries. Food, water, the poverty is much larger than any one of these things we're going to talk about. So the developing countries, we've seen improved morbidity and mortality, again, not because of antimicrobials, most likely. It's because we feed them, because we feed our brothers and sisters, and that we have improved sanitation in the world. We have vaccines that we use. Okay, but still, infectious diseases disproportionately affect all age groups. Again, poverty, inadequate public health structure, poor sanitation, and poor vaccination coverage, no matter what we think. There's 2 million people infected with antimicrobial resistance. And 25,000 of them die annually. This is the present day. This is going to be geometric unless we do something about it. So the resistance can be natural, genetic mutations of microbes, one species acquiring resistance from another. We share with our brother animals, our porcine, our bovines, our chicks. We share. Influenza is a good one. Suboptimal dosing and misuse of antimicrobials, done all the time. So what are we going to do about it? So the significant bacteria to date, penicillin resistance, Streptococcus pneumoniae, MRSA, VRE, and the multi-drug resistant gram-negative bacilli, like E. coli, the Klebsiella. And again, we're not going into great detail here. So the resistance causes, the natural resistance, very difficult to change, if not impossible at the present time. Resistance that's acquired is acquired because of misuse of antimicrobials by us. Okay? Misuse and inappropriate antibiotic choices by unskilled practitioners, semi-us, and laypersons. Who here has never taken an antibiotic? Who here has never prescribed an antibiotic? Ah, very good. You do even better, I hope, after this. So there's poor quality medicines in parts of the world, dissemination of organisms due to overcrowding and unhygienic practices are the leader of obvious infectious disease overall. So inadequate infection control and prevention, inadequate surveillance, poverty, inadequate resources to implement strategies against antimicrobial resistance. I apologize for some of the abbreviations. And basically a lack of political will. However, there is a move afoot. So the Joint Commission, who here has never heard of the Joint Commission? Well, that's a good start. Okay. Well, you know the Joint Commission is private. It's just hired out to the CDC, who does, and CMS, not CDC, CMS, to accredit us to see if we do such a good enough job to be given the funds to look after people. Anyway, it's actually done a good job no matter how we look at things. It's improved medicine overall. A new standard came into being the year before last called and those of us who get into Joint Commission, you start speaking this kind of speak, MM090101. Whether it's management, infection control, is med management. So although this Joint Commission policy came out, it directs that the antimicrobial stewardship is really the purview of infection prevention and control. However, it's under the pharmacy aspect, the med management. So all healthcare facilities, that means everybody funded by CMS, had to be in compliance and had to have an antimicrobial stewardship plan program by January 1st, 2017. We're over that hump. No, we're not. We're still developing our stewardship program, as you will see. But actually, CMS was going to come out with the same policy in January of, let's see now. Actually, it got postponed because of the presidential election. So all the things that were, well, not all, excuse me, a few healthcare directed policies got delayed, and actually the CMS has not defined a stewardship program yet the Joint Commission has mandated it. It's okay, it's all positive. So the purpose was to reduce the unnecessary or inappropriate antimicrobials in healthcare settings with the goal of reducing resistance. As we know, 20 to 50% of all antimicrobials used in the hospital, this data is well published, is unnecessary or inappropriate. So everybody's going, like I do, please define unnecessary. Please define inappropriate. Okay? There is no singular definition of inappropriate. Okay? If you're giving, we know post hoc what we've done with it. We've given azithromycin for a virus. That's inappropriate, right? That's one of the things we do frequently, actually, as a group. So the president, looking at what was happening in the world, came out with a white paper on antimicrobial resistance. So everybody in infectious diseases says, I got at least another 10 years to practice, right? We can maintain our jobs and everything if we just concentrate on this. This became a national awareness program that started with the CDC. In 2015, the White House hosted a forum of antimicrobial stewardship, antibiotic stewardship it was called, for the national and international approach to this problem. Oops, that won't get us anywhere. So here you can see in 2014 that the CDC released it's the U.S. National Strategy for Combating Antimicrobial Resistant Bacteria. This is the national strategy, meaning we will do this. This is the commandment that's gone forth. And the guiding principles you can see, again, misuse and overuse in healthcare and food production. So all the national strategy includes all healthcare, human healthcare, and animal healthcare bodies. So again, here's the statement was all of us who depend on antibiotics must join in common effort to detect, stop, and prevent the emergence and spread of resistant bacteria. I know, you've heard this. You're going to hear. Here's some interesting things. Just a quick look. Man, I think it must have had astigmatism. Is that blurry to you? Anyway, here's the things that have changed. Interesting. For cellulitis and soft tissue, we've come up, and in our own division section, we've discussed this. Where's the basis? Where's the evidence base? 7 to 14 days, 6 to 8 weeks. We're still hunting for some of that evidence, right? So most of it is consensus. Evidence-based medicine, sorry to use that. Evidence-based medicine, much of it is consensus, as we know. And that's how we develop guidelines. The guidelines, again, are guidelines. Anyway, we thought standard was 7 to 14 days or 10 to... Now we find, and here's the references, 5 to 6 days for cellulitis. That's sufficient. CAP, we went from, interestingly, from 7 to 10 days. Actually, it was 14 days before that to 5 days. CAP being community-acquired pneumonia. Okay, ventilator-associated pneumonia, again, even though we may have some fairly resistant bugs, we got to treat the disease, and the suggestion now is, and the support is for 7 to 8 days. This one I find the most interesting, of all. Let me see where it... maybe it's not on here, is with, here it is, yeah. Intra-Abdominal Infection, right? With source control, at first we thought 7 to 14 days. So drain an abscess, treat for 7 to 14 days. Well, the new guidelines suggest, not guidelines yet, that we can treat, if we have source control, we can treat for as little as 4 days with an intra-abdominal process. Again, a treatable one, not the patient that we have seen recently who has atypical mycobacteria in their belly. We're not sure how long to treat that person, a year maybe. But you can see the point being that, where are we going? So you can see that that we're evolving into a state where we can treat people for a much shorter time with the antimicrobials. Why? Well, 2 million illnesses and 25,000 deaths occur. I've alluded to that already. Globally, it's interesting, 30% of neonatal deaths, greater 50% of neonates with ESBL, and 50% with MRSA die. So we still have people dying from their resistant organism. There are a lot of other factors in there, of course, in the developing countries, again, poverty, etc. Just the annual cost of illnesses, you can now see that antimicrobial resistance costs about, and this is an old number, is $55 billion a year. That's it's 15 years later now. I haven't found updated data. So the World Health Organization has put out a list of things perhaps we as a world should look at and what antimicrobial agents we should look at as critically important, highly important, and important. All this is a guideline to, well, how are we going to deal with this? What should we protect first? Okay? So the important antimicrobials in medicine, so here they are, and you can you just note that the highest priority, and this means that we need to protect this group more than this group, more than this group. That doesn't mean we need to protect them all or deal with them equally. And here this is the criteria that they use to define this list. Okay, one is there anything around that we could use instead of X? Can we use Y instead of X? And if we can't, then it came up to the number one criteria. Again, down at the bottom, you can see they're important, but the criteria and the prioritization for this group is minimal. So what the Global Action Plan 2015, the World Health Organization, was improve the awareness and understanding of antimicrobial resistance. One of the reasons I'm here, right? So we need to strengthen surveillance and research. Our infection control people and our pharmacy and are working many hours to try and develop a better understanding. We are expanding our stewardship program. It's not like we didn't have one. It's not like the Ochsner health system didn't have one. It's that now we're going to integrate, and we have much greater resources to expand and do a better job right here in River City. So reduce the incidence of infection, that's better prevention. And that doesn't mean with a drug. Okay? Optimize the use of antimicrobials, that's a broad statement. I'm not going to go into detail, but I may at another lecture. Ensure sustainable investment, countering antimicrobial, sustainable investment. That means our investment in hours, investment in concern for the patient, but investment in monies by administration and our support that way. So if we look at, are we going to a pre-antimicrobial era at the present time? Here's a replacement, with the amputation being the proxy for hip replacement, which looks pretty gross, and is simplistic. So if we use prophylaxis as standard and we end up with an infection rate of 0.5 to 2%, okay, most of the patients don't get infected. Those that are successfully treated, right, because of this prophylaxis. Without antimicrobial prophylaxis, we will see a 40 to 50%. Now that's hard to believe, but it's still 40 to 50%, and 30% mortality with our joints. And you know how much our joints cost us over time. Well, it takes into account quality life years as well, and that, but the mortality is 30%. So you can figure the result of our loss of antimicrobial use. That's the point. So we need more interventions proposed that encourage conservative and appropriate use to slow the progress of resistance. Or maybe it's too late, like we were with MRSA. Oh, we should isolate them. Oh, yeah, we should. Okay, maybe we won't. Maybe we should maybe we should do nose and throat cultures on everybody that's admitted. And maybe we can prevent MRSA. Well, MRSA got out of the gate. We were so far behind that. Now, interestingly, we are at a point where we're debating whether we should isolate people with MRSA at all. We won't go into that today. So is it too late? Why aren't we doing more? So antimicrobial resistance, it's evidence-based policy making. And we have a problem. The government needs to make decisions. We need to help the government make decisions. So prioritize our health problems by economic burden, cost effectiveness of interventions. So we are really being unable to show that antimicrobial resistance costs enough to be a health priority. More research, more investment in time to develop this. I must say that the Society for Healthcare Epidemiology of America and the IDSA are leaders in trying to develop these priorities. Okay, so what are my key thoughts? My key thoughts, maybe yours. An increase in resistant organisms coupled with a marked reduction of new antimicrobials really suggests an apocalyptic scenario. I mean, it's looming. It's very hard to get that across unless you're going to see your patients die from lack of antimicrobials. Has anybody here had a patient die because there was nothing left, no antimicrobial left to treat them? Yeah? None, zero. There wasn't anything available. So again, oops, sorry, I'm pushing the wrong button again. Okay. Current estimates suggest antimicrobial has low economic impact. We know such estimates don't take into account that antimicrobials is an integral part of modern healthcare. I mean, it's hard to imagine. Imagine what would happen if we had no antimicrobial. Every aspect of what we do, every aspect of healthcare involves antimicrobials, one way or another. Infectious disease has the luxury and the privilege of touching every specialty and every subspecialty. Stewardship is not just an idea. It's not an ID, an infectious disease demanding attention. It's everybody. So the total cost may be inestimable. People have tried to see each procedure what cost it is, and we're not going to each procedure. So we need greater investment in antimicrobial resistance as it's an insurance policy. We need to move forward with all of the things I've said already. Who's going to do it? You and me, all of us. We are all stewards of antimicrobials, right? So when are we going to do it? We have to do it now. Every day. Every antimicrobial agent we use, every antimicrobial we see everybody else use, and I don't mean antibiotics, antibiotics, antimicrobials, antivirals, antifungals. We have emerging resistance. Sorry, this wasn't color until I smudged it. But anyway, the conundrum is where are we going to get this? How are we going to do this? You know, where's our administrative support? Where's our funding to do this? Where's the direction? I mean, a stewardship program, thank God we're about to get a stewardship pharmacist, directed pharmacist here, and we'll be moving forward with our stewardship. We're going to make it more robust. But just to point out what it takes, okay, here's us, the clinical pharmacist and the ID physician, involved in stewardship at the present time. So this also should embody all of us in this room, right? And we have pharmacy and therapeutics group and microbiology, okay, epidemiology, infection control. I mean, this And here's the most important one right here, administration, to help support all of us. We need quality and safety, and then our information systems is huge. I've just got a word, communication. We have to communicate, a lot of we is right here, it's royal, is that we have to communicate with each other on a daily basis about antimicrobial use. How, when, and that's our goal, is to develop a stewardship program where I can call the surgeons, or I can call the nephrologist, and I can go, hey, what's happening with the antimicrobial use? What's your input? How you're using it? If anybody prescribes antimicrobials for somebody on dialysis, it's a guide to, do we really know what we're doing? Is the drug still there? Is the drug going to get to where we want it? Do we use it after dialysis? Can we use it before dialysis? Anyway, it's a huge undertaking. So what we're trying to do at the present is improve our existing stewardship by making it more robust. We have the skeleton here in this institution. We're trying to make it more robust, and we will make it more robust. So it's an integral part of our institution, and it's huge. Most of our prescriptions are outpatient, not inpatient. So inpatient is just the beginning. So our hope is to start with the tip of the iceberg and work our way down. It's not new. I mean, the state of California mandated that stewardship programs would exist the 1st of January 2007. Hopkins has worked on their stewardship program since 2001. But the state of California mandated, so every acute hospital, it states, should have a stewardship program in 7. My point being, all those resources out there for us to build our own and make it better. So what we do is we teach every day the use of which agent, when, should we give it now? One of my things when I make rounds is, why did you give an antimicrobial agent? Was your patient going to die? What's the rush? If your patient's going to die, yesterday is good. Okay? But what's the rush? The rush is we haven't got we've ordered a bunch of tests, we haven't gotten them back. And the problem with infections is if signs and symptoms, you can have a non-infectious disease line up exactly the same way. So IV to PO bioavailability, this took some time that we can actually use quinolones, that we can actually use linezolid with just PO. We don't really need IV unless the circumstances dictate that. We need to move to a narrower spectrum in short order. We're developing IT flow for antimicrobials so that we can match the bug with the drug and say, okay, we can narrow our spectrum, okay, in order to protect our broader spectrum agents. In the developing world, in India, in parts of India, carbapenems are the first drug of choice for gram-negative infections in the neonate because all the others are resistant. Okay, the longer the duration we know, the greater the risks of unintended consequences. Clostridioides difficile infection, those of you who are on the ball will notice it's not Clostridium anymore. And that's side effects, nausea, vomiting, diarrhea, so common with all the drugs we use, right? And allergic reactions and colonization with resistant organisms. There's no question we use an antimicrobial agent, we change the microbiome, the gut microbiome. So how do we do this? We have standard clinical guidelines and order sets, which everybody here should contribute to. Guidelines are guidelines. Clinical judgment's clinical judgment. If your clinical judgment's bad, the guidelines really help you. If your clinical guidelines, if you're really swift on the ball, then your clinical guidelines just reaffirm what you're doing. So we have Get Smart campaigns. There's world campaigns of antibiotic awareness. Antibiotic Awareness Day in November. Those of you who missed it, I'm sorry. But next year, there's going to be a hoopla. Okay, data. You hear this over and over again. Well, finally, we've developed a standard antimicrobial agent usage ratio, okay, administration ratio, by the CDC, where we can input our use. It becomes public domain, so we can compare ourselves across the country to other institutions. Without that, we know less about where we stand. Okay. Okay, so in order to develop the infrastructure, we need the core members of a stewardship team, all right, which means it coordinates so we need an infectious disease physician or hospital epidemiologist. You don't absolutely have to have this. Many hospitals don't have an ID physician or hospital epidemiologist, but somebody interested in doing stewardship. So they coordinate, and these are just clinical pharmacy, maybe that's Freudian. Okay, we need an information system specialist, a microbiologist. You can't do any stewardship without a good microbiology lab. There's all data. We can present a whole lecture on just the advantage of a good microbiology lab to stewardship. And the infection control prevention specialist with stewardship and infection control, my bias is we actually could run everything in the hospital. Listen. Because everything we touch, literally, comes under infection control. Nursing you can't do stewardship without nurses. Nurses have to buy in, and we have to support them as physicians. And our hospital administrative officer, although last on the list, is actually first on the list, the director of patient safety and quality. There's quality and safety, before I stop, quality and safety officers, institutions that work for the CDC that are all around us to help us define better what we're doing and how we're doing it. Just to do our outpatient stewardship is huge undertaking. Okay? So our goals: optimize patient safety, right? Decrease the control cost to the patient, cost to the bottom line budget of the institution. Why are we buying expensive drugs if we're not using expensive drugs? Can we narrow the formulary down? All these questions in stewardship. And then again, we want to reduce the resistance of microbiological organisms. Again, we do not have a large number of resistant organisms that, other than MRSA, VRE, but not the KPCs and CREs. We aren't seeing them yet. Okay? We are looking. We are trying to identify them better. Oh, sorry. Where are we? Okay. So to date, we have developed some guidelines. We're going to increase our robustness and continue to be based on the current literature reviews. Everybody has the feedback. We're going to arrange how you're going to get the feedback, okay? Including national societies, guidelines, consensus statements. All of these things are important to the accurate and current local microbiological data. Our lab, you need to have our lab's data. What happens at Hopkins about the resistance counts a little, but not as much as the data from here. So everybody should have an antibiogram. Everybody should be using it. Okay? How are we going to do this? So I just want to touch quickly, very quickly, on RDTs, which are rapid diagnostic tests. They're not the end-all and the be-all. They certainly get you to make a decision or help you make a decision quickly. Right? Our conventional approaches to things have taken anywhere from 3 to 5 days for culture, growth, susceptibility. It's all gotten improved. But things like MALDI-TOF, mass spectrometry, I'm not going to tell you what MALDI-TOF was, and NAATs, right? Like all the PCRs, those are important, and antigenic tests or antibody tests. They're all the interesting thing, and the most important thing is they're all biomarkers and surrogate for pathological processes, right? They don't tell you what disease is. Somebody says, well, how come you told me I had lupus, but all the lupus tests are negative? Okay? How come you told me I had E. coli, but I didn't grow E. coli? Well, I had E. coli last week. You've been on suppressive antibiotics since. So what are the pros to these rapid tests? Time to identification, susceptibility of bacteria and yeast, no question. You can get them in hours. Financial savings based on reagents and tech time. There's no question that when you get a MALDI-TOF, that you can actually reduce the number of not only tech time, but techs. Now, the lab doesn't want to hear that, but we can use them for other things. Okay, what are the maybes? Decreased time to optimization of therapy? Maybe. Reduced length of stay? Maybe. Improved patient outcomes? Maybe. Decreased overall hospital costs? Maybe. Why are they all maybes? We don't have supportive data for the maybes. We have not got enough random control trials to define any one of these at the present time. But thanks to our expanding research and stewardship, we are going to get there. So we have to, philosophically, we have to deal with uncertainty about clinical and economic impacts of increasing resistance. So, and we use the tried and true, which is insurance, which means we have to make an investment. So insurance, you make the investment and you collect later, you hope, right? Antimicrobial policies should not be viewed as a cost. This is an opinion, okay? Viewed as a cost, but rather an insurance policy against catastrophe, because we are certainly headed towards catastrophe if we don't handle these antimicrobials better. So moving forward, we've got to improve our health care infrastructure. We have to somehow we can argue all this. Health insurance for all. I think as a society we should demand health insurance for all. Limited drug advertising. I don't know whether I'm the only one, but we were discussing whether in fact drug reps should come into the institution and what we have to gain from that, or what we have to lose from that. Standardized infection control policies, we have them, we're improving them, and we are creating new ones as we move along. Surveillance, we're getting better at surveillance of our antibiotic use. It depends on you. You find a bug, you make sure that everybody knows about it. A resistant bug. You find a bug, I'm happy to hear about it. Any one of them. Surveillance, again, in humans and animals. We need sufficient staffing. Huge issue, right? Everywhere we go. ASPs in all healthcare facilities. Every one of our healthcare facilities that will be our Ochsner LSU facilities. And again, so what have we got? Oh, I'm sorry. We've got some references here, but there's another 3 or 4 slides with references on it. And I know this is just the tip, right? This is, if we're going to talk, I can, if you wish, and I'm sure I will, talk about rapid diagnostic tests in another lecture. What we're going to do with surgery. What we do with prophylaxis. Prophylaxis is a huge issue. Are we getting the drug to the patient in time? Are we redosing in the heavyweight patient in mid-surgery? Or if the surgery takes 4 hours or longer, are we redosing? That's just prophylaxis. Are we using it properly? All of this is measuring it, demonstrating to you that we are doing these things, and you demonstrating to us that you're invested in us demonstrating it. Questions? Arguments?
I have a question about communication with the outpatient or at discharge. Do you have any evidence of how often patients do not understand or don't adhere to the duration or the treatment regimen with antibiotics? Like they felt better or they didn't like the diarrhea or whatever, that they quit taking them?
The answer is no. We don't have any data. You mean our data? Right. I mean, it's a very...
the patient is treating themselves when they're at home. And I just wondered about the communication. Are they really clear about taking the whole dose?
Patients, or the human ones we deal with, are human, and we're all fraught with error. So we speak to them and do we understand what we've just said? Do we understand what we just said? Never mind, they understand what we just said, right? But to your point, it's one. There's a whole ship. We need to improve the workflow to the outpatient, right, area. But we also need to improve our intake, our history and physical. Our histories are a bit of they could be better. So because especially the bias about antimicrobial, not are you on antibiotics? Have you used antibiotics in the last 2 weeks? Questions like that. I know they're not there. So the patient comes in with diarrhea, and like you said, diarrhea, you go, well, this is self-induced. Why? Because I took my mom's drugs for the last week. Or a week ago I took them. And now I've got diarrhea ever since. And you can see where this leads, because then we go, okay, we'll look for C. diff. And we go, okay, it's positive for C. diff. Well, do we have disease, or we just have C. diff? Right? I mean, that's another lecture, just C. diff.
Also, Oshner, if I was the queen, someone would be calling and checking, a PharmD would be calling and checking on medicines they're taking and how they're taking them. There are studies that have been done that 20 to 50% at discharge are not taking them as you guys thought they ought to be taking them for one reason or another.
I can tell you there's the undertaken by the Oshner specialty pharmacy is going to handle hepatitis C drugs. They have a very well oiled, very well tuned workflow with following up on patients once they're given the drug. They're introduced to the drug before they get it. Well, if I'm prescribing, they get introduced to the drug, then we prescribe it, but then they get introduced to, you do understand from the specialty pharmacy in New Orleans, do you understand why you're doing this and what the side effects are, etc.? Okay, then they deliver the drug to the patient, and then within 3 days they make another phone call. Did you get the drug? 1 week after that, they phone again to see if there's any problem.
And this is Walgreens. Surely Oshner can do this.
No, this is Ochsner. This is Ochsner's specialty pharmacy. They are doing that now. But that's with the hepatitis C front. I don't know about generally, to tell you the truth, but I will find out and give you the answer.
I think the biggest step is to get, like you spoke about rapid tests. If you have a BioFire or MALDI-TOF, when patient comes into the ER and you run a quick BioFire or MALDI-TOF, how it's done in most institutions, maybe started 10 years ago or 5 years ago at least, where you run a rapid test, and if the lab can tell the physician taking care of a patient in 1 hour, hey, listen, your patient does not have bacteremia for whatever reason, or has a gram-positive something or gram-negative, the patient doesn't have to get vancomycin or vancomycin for 5 days till a conventional lab calls and says, hey, your blood cultures are positive. So I totally understand that when someone comes into the ER and has sepsis, for the residents or the physician who's taking care of the patient, it's not easy to say, okay, don't give any antibiotics. Because that takes a lot of courage to not give antibiotics. It takes more courage to not give than to prescribe antibiotics. So if you have a test that can support your, or some sort of validity that you're not doing harm to your patient, like by simply getting a MALDI-TOF, like the first thing is to beef up what you have in an ancient microbiology lab that takes days and weeks for things to come back. Then you can simply stop antibiotics in 24 hours.
Right.
Or not even start it in the first place. So for a lot of times patients come in and have this coag negative staph, a MALDI-TOF will tell you like in one hour, your patient has GPCs, but they're not Staph aureus.
So
there's a lot of things, Or for instance, a viral illness. They come in with a viral illness, and it'll tell you if they have bacteremia or not.
To your point about sepsis is the clinical judgment at the time. So we're not waiting for any tests, right? It's sepsis.
Right.
Now, we're not going to say we're going to delay it in that particular case. However, the data, the published data supports that the rapid diagnostic tests by themselves do not improve antimicrobial use. that it takes, it works better in conjunction with a stewardship team.
Right.
And then you have better outcomes, process outcomes and clinical outcomes. That data is available.
Yeah, but I'm sure, like for an institution like this, I'm sure it wouldn't take 5 days before you even know if we wait a long time to know what is happening, in the micro lab before we stop anything. Like people are on extended gram-negative, gram-positive coverage for no bacteremia at all, right? So I feel like it just helps the physician taking care of the patient to know what exactly they're treating, and that kind of makes medical decision-making a lot easier.
Exactly right. That's what all the rapid diagnostic tests do, to help us make decisions earlier.
Yeah.
You're right. And to that point, as you know, we're reviewing some of the, like we have MALDI-TOF. It's first generation MALDI-TOF. So we're looking at how we might improve some of that approach
Which generation
in our lab.
are we in? MALDI-TOF, I don't know. What generation is the current do we have, I'm sure we have
We
newer
have the very
MALDI-TOF.
first MALDI-TOF generation.
Well, what is the latest generation?
I think there are modifications on generation. So it's, I think, 3. Yeah. Anybody else? So what are you going to do with those antimicrobial agents in your cupboard? Right? Don't tell me you're going to throw them down the toilet. Just don't tell me that, even if you do. That's another issue.
I thought you were supposed to take them as prescribed, so you wouldn't have any.
That's right. We wouldn't have any left. But how many of us have prescribed a few more because now it takes another 3 days to reach the payer to get the refill? We're into that part of the world too. So there are many, many things we can do something about. Many we cannot at this point. Thank you so much for being here.